telehealth is so critical. So what we want to do with this program is we want to start out, again, by giving you a broad foundation of understanding. And Stuart Levy, President of Health Promotion Solutions, is going to give you that overall landscape of what telehealth and telemedicine is all about. And then again, we will drill down to the employer level, and we'll have Donald Lentini from Pitney Bowes talk about how telehealth is functioning in their operation. So let me start by introducing Stuart. Stuart Levy is the President and Founder of Health Promotion Solutions, a consulting and solutions provider focused on evidence-based solutions for the prevention, detection, and management of chronic diseases. His clients include many Fortune 500 companies. His 28-year healthcare career includes senior-level sales and marketing positions in pharmaceutical industry and on other accounts. So please welcome Stuart Levy.
Thank you, Larry. I'd like to start by saying the opportunities for telemedicine are so dramatic and so exciting. And as I sat here listening to all the discussion, the common themes about quality and accreditation, engagement of high-risk populations, creating staffing efficiencies, and better quality of care metrics, what telemedicine offers us is a way to expedite those processes. And actually, when you really think about it, the other theme I heard is the fear of the unknown, because many of the obstacles, and I'm going to share that with you today, to the implementation of telemedicine solutions have now gone away. And that's the exciting part as well. So with that, I'm going to go back to the future. And all the Cubs fans, of course, know why this is significant, because in 1985, Michael Fox took a journey to way in the future, 2015. And one of the predictions was the Chicago Cubs are going to win the World Series. And wouldn't that be destiny or religious or spiritual if it actually happened? So all of us, even Milwaukee Brewers fans, are rooting for the Cubs, except for a few St. Louis Cardinal fans. But I don't know that Michael Fox would say anything different, really, of how our healthcare system looked in 1985. I mean, we had brick-and-mortar hospitals still there being built and doctors doing fee-for-service. And, yeah, we're making some inroads with patient-centered medical home and accountable care organizations, but we're at that tipping point, right? And we know we need to reform. But really, the healthcare system didn't look that much different 30 years ago. But what about 30 years from now? What if we were in that DeLorean or Lamborghini, take your pick, and went 30 years from now in 2045? And I would argue that our healthcare system is going to be amazing, because what we're going to have is collaboration of data. We're going to have EHR systems talking to one another. We're going to have organizations that are going to be making money on prevention and wellness and accountable care and going at risk, and most importantly, having the tools and analytics to do that. And then the third thing is we're going to have staffing efficiencies. All of you that manage a clinic, I can't imagine the pain that you must have with staffing efficiencies. Not enough staff, on-call specialists that didn't show up, and all that. And the good news is the future's here. We don't have to wait for 2014. And that's what I'm going to share with you as well. 3 agenda points, give you a little background about ourselves, talk about this evolution of digital health. The other takeaway I'd like to share with you is there is a next generation of telemedicine and telehealth, which are many times being used interchangeably. I'm going to talk about telepresence. And then the third thing is, how do we pull it all together? What are the other tools that a telemedicine clinic, telepresence clinic would need to be successful in managing patient care? We've had the good fortune of doing consulting and actually doing programming. We have 2 divisions, consulting and programming, to actually put wellness, evidence-based wellness programs in place. And what you'll see is a list of important organizations, including Building a Healthier Chicago and Community-Based Wellness, because you can't change an individual unless you change their environment. So we did a lot of work with Health and Human Services, but also specifically I'd like to point to 2 types of clinics that we've done consulting with. Retail clinics to support chronic disease expansion, and also employers to be partnering with the Take Cares and MinuteClinics of the world. And secondly, helping federally qualified health centers implement telemedicine and also chronic disease management. With that, you'll see a lot of hard-to-reach populations and employer groups we've had the privilege of working with. And now our greatest growth is hospital systems. It's kind of scary because it kind of reflects our healthcare system that we're helping Wake Forest Healthcare System and Rice Memorial, Minnesota, and a lot of regional hospitals learn how to do population health. and health screenings and HRAs, things that you guys do all the time. But now, as they go out in the community and do population health, it's a great opportunity for us to really help those types of organizations. And again, enough about us, but we do have some credibility, and I want to make sure that you have that background. So what are the trends? What are the opportunities as well? Certainly the growth. 3 years ago, the growth of the market for telemedicine solutions was $18 billion. This year, it's $27 billion, and it's exponential. The biggest growth is wearable devices and at-home monitoring. Number two, that consumers embrace the technology. I think the perception is, well, older people aren't really going to like it, and people are going to be scared with it. That's not the fact. And for those of you, I know many of your organizations, almost all of you, are implementing some sort of telehealth or Skyping and all. You're seeing very high satisfaction rates. It has proven results, and I'll share some of those with you today. EHR integration is becoming more feasible. How many of you are aware of the Commonwealth Health Alliance? Okay. HIMSS conference in Chicago 3 months ago, they basically announced this alliance of 12 of the largest EHR systems to be able to talk to one another. So Epic and Athena and all the big ones out there are now sharing common data fields that will allow an opportunity to build a telemedicine clinic, picking your software of choice, Athena or whatever is being used, and then implement that into a provider group or into Epic, which is really exciting. I'm going to share with you some flexible types of telemedicine solutions, specifically on the technology side. And then the good news of the day, unlike typical government, I didn't want this to be political, getting in the way of expansion and success in healthcare, what I'm going to share with you is that the state and federal governments are promoting the heck out of telemedicine, and they see the value of it, and they want to see it succeed. So a lot of the stringent laws and a lot of the things that we were worried about are now going away. And that's the fact. The VA is the largest purchaser of telemedicine, mainly cart-based systems, and they're a proponent. This has been used for a lot of psych counseling for our soldiers who come home, uploading of radiological exams so an individual doesn't have to travel 3 hours to get a specialty care. The government is a huge proponent of telemedicine. And then secondly, there are Medicare laws that may favor expansion for those organizations that are dealing with retirees, because in 2016 there's an opportunity that in the city of Chicago that Medicare reimbursement would be established in major metro markets. For those of you that are familiar with telemedicine, you know that you have to be outside, 40 miles outside a rural community at a geo map to be billing for Medicare. Well, that's proposed to be potentially going away. There's now over 27 states that are mandating private pay insurers to pay for insurance. But I'm going to give you an asterisk and say that it's not that simple. Florida has been one of the more recent ones, and I'm going to cite them as an example, and also Texas. We were talking to one of the colleagues here from HEB that's implementing clinics there. They've actually clamped down on some of the telemedicine because they want the standards to be of high quality, and I'm going to share with you what that all means. So as far as the proven results, probably the number one concern for you all is staffing efficiencies, having real-time ability to have a physician on call at the time when they need to be on seeing a consult by a video. Certainly we know the value of ER triage and emergency room types of assessments. Third, the opportunity to bring in specialty care, and I want to go there a second. How wonderful would it be to have your primary care clinic, nurse practitioner, be able to have the ability to have a dermatologist, a physical therapist, an orthopedic physician, you name the specialty, they're available real-time through an appointment for that primary care clinic that you typically, can only staff primary care. I shouldn't say only. There are ways to bring in specialty care, but it's cumbersome. Having transdisciplinary network providers, we think this is a very big opportunity, and I know we talked about it a lot today, but for certain disease states like diabetes and others, it's the real value to have the dietitians, the health coaches, the fitness trainers that we've learned about, and many of which are becoming reimbursable. Ease of patient transport, reduced time to urgent care. This goes on and on. Cost effective to manage an on-site clinic, and this one is important to you all who are on site as an employer clinic or employer clinic provider. The build out of a telemedicine clinic that I'm going to show you in a few minutes is 30 to 40% less than a traditional medical clinic and doesn't require the same space requirements. And it can operate more efficiently. The other point I think that's important is, and we talked about this a little bit over dinner last night, was I know so many employers would love the ability to offer those same services from that corporate medical clinic to the sales force or the distribution and the remote sites that may only have 300 or 500 employees. Well, establishing a telemedicine clinic allows your practitioners who are in your main clinic to be able to practice outside of that clinic and be able to serve the needs of those remote locations. These are all the transdisciplinary telemedicine providers that are approved for telemedicine. So what are the challenges? And I would say that each one of these is now going away, every one of them. Scalability of platforms, bandwidth. Many of the telemedicine providers that were probably presenting in front of Larry, American Well, NV Live, these organizations are investing in infrastructure to allow a much clearer transmission of the video and the equipment, and they're forming relationships with the Verizons of the world. Security. We know that cloud-based security can be implemented, and that issue has helped prevent a lot of the issues that we're having with HIPAA. Provider training and certification is an opportunity, and I was so glad to hear the panel up here talking about credentialing and qualification of staff and clinics, and I think that's going to be a really important thing with telemedicine going forward. Because I don't know about you, but I get very nervous speaking in front of a group. But if I'm in front of a camera or a video, it's, oh my God, first of all, you got to watch out what's behind you. And then secondly, it's a different skill set. So there's not only training to how to present, but also who is certified and trained to be operating those clinics. We talked a little bit about the interfacing of the EHR systems as a challenge, but also going away, and the state regulatory laws, which were a challenge, which are becoming much more lenient. And as I mentioned to you before, the Commonwealth Alliance is something you might want to Google and learn more about and find out what EHR systems you're involved in. But it's nice to see organizations like Kaiser and others helping bring these EHR systems together to try to form common ways to share data and information. Telemedicine is governed by the state, and what I wanted to share with you is some 101 kind of things that the states look at. First of all, they can decide to reimburse or not, so it's totally optional. Number two, they can decide on the technology, the types of technology that can be used, so they certainly are involved with that. The location, origination and destination. This is an important aspect because where the origination is where the patient care is being delivered. Where the remote location is as long as it's an accredited physician or transdisciplinary provider, which I put up there before, they're allowed to practice remotely. So that could be your NPs, your physicians at home in their pink fuzzy slippers on maternity leave, whatever. There's opportunities to utilize staff outside your brick and mortar, opportunities to optimize the remote locations, distant locations. Now, generally, Medicare has some guidelines that they'd like them practicing in a clinic of sorts and so on and so forth, but check with your states because the opportunity to make your medical clinics not only an origination site, which is what they are now, that's where they're seeing the patients, but why not make it a distant site? Why not have those same physicians and nurse practitioners who aren't seeing a patient be able to provide care remotely? And that makes them a remote destination, and it would be approved under reimbursement laws. First patient visit. This is a sticky wicket. And for those of you that are familiar with telemedicine, you know what I'm talking about. There's 10 states that allow the opportunity that I don't have to have a prior relationship with that clinic or hospital system to be seen. So if I've got a sinusitis, if I've got whatever condition that would be governed under telemedicine, I would have the opportunity in 10 states to be able to not have to have a prior relationship with that clinic. The other 40 states, they're saying, no, time out. You got to know who that provider group is because of medical records, and that's an important thing. But this is an area also that the government is becoming more and more lenient because there are exceptions, there's opportunities where patient care could be delivered and should be delivered on more simple, probably acute care types of conditions. So I'm not a legal expert by any stretch an imagination, what I'm here to share with you that this is an area that is becoming a hot topic and, from the medical associations, which I don't blame them, but also, again, the government, state and federal, wants more and more of this opportunity for those patients that may need it. Reimbursement levels. Also an issue in the past and less of an issue going forward. Typically a telehealth or a teledoc type acute care or experience, even Skyping, is discounted from a standard office visit. Usually, typically, there's a qualifier code and it's usually 30%. What I'm going to share with you in the newer next generation telepresence video type imaging, which is about a real-time office visit done virtually, they're getting 100% reimbursement from all the carriers except for one, and I won't name them. But United Healthcare, Cigna, have been big proponents of telemedicine, and so that's the exciting part, that as the technology improves and the opportunities become that we've put the infrastructure in place, that the carriers are going to look at this as the same as a real office visit. The qualifications can also be governed by the state as to who's qualified. There are some states that don't allow nurse practitioners. Florida's one of them, and they're trying to petition for that. They allow PAs and physicians. But for the most part, nurse practitioners and the rest are really governed to be able to provide reimbursement through private pay. I think all of us are aware of the security that needs to be involved with any type of clinic, but just like any kind of telemedicine clinic, they would have that same standard. So I love this. 1924, remember we talked about Back to the Future? This is a young boy, and that's his image right there, and that's the doctor. And there's the kids kind of joking with him, but in it is his sound system, and the doctor's seeing this boy on the little screen, and everything's connected, and it's about radio, because radio was basically invented in the teens or whatever else. So we've known about telemedicine for a while. So the question is, we haven't come very far from this concept, and what can we do to expedite that? So what I'm going to start with is definitions that are not being followed, and that's okay. That happens in healthcare all the time. But if you look on the American Telemedicine Association vocabulary or explanation of what telehealth is and what telemedicine is, there's a big difference, because telehealth can be a healthcare consulting without a practitioner and a diagnosis. And health coaching fits into that. Teletriage fits into it. You wouldn't necessarily have to have a provider there. And also all this digital stuff that there's now 42 different types of accelerometers and apps we can download. These are all forms of telehealth, and it doesn't have to be done under the pure sense of the word telehealth. And there's lots of good results from teletriage and telehealth, health coaching. We know behavior change programs work, and that's what telehealth's all about. So I'd like to call what we're talking about digital health, and I think the APA's kind of hesitant about it because they love their name, but it's not telemedicine, it's really digital health, all this stuff, right? So digital health telemedicine is the ability to have a practitioner and upload x-rays and radiological exams, which have been done for decades, since the 1970s. Telehome monitoring would fall under telemedicine if it's interpreted by a clinician. So for the rest of this presentation, I may use telehealth and telemedicine interchangeably, but at least from a qualification standpoint, I wanted to share with you the telemedicine is actually done, in the true sense of the word, by a provider interpreting it on the other actions. Now, for those of you that are implementing telehealth, telemedicine, I should say, with practitioners, telephonic telemedicine works, and this is results from Teladoc, and it would see the same thing from MD Live, so there's no commercial here. Great satisfaction. It's interesting that the individual, that employee, doesn't necessarily have a prior relationship with that doctor on the other side of the country who may have qualifications to prescribe in that state but may not have that prior relationship. But people are satisfied from the convenience and the quality of care, and you can see that most employers have kind of built telehealth, telemedicine, into their benefit design. But typically, there are limitations, as you all know, to the certain 14 types of conditions and certain basic wellness that can be offered through telephonic and even through video Skyping. So the next generation have now incorporated medical instruments into it, and that's where we get into some of the newer technologies and different types of solutions that could be something for you all to evaluate. So telemedicine carts are very, very popular in nursing homes and VA. Our organization had the privilege of setting up a Parkinson's network in New York State, Delaware, and New Jersey, so that Parkinson's patients didn't have to travel 3-4 hours to go to Baltimore or Newark or New York to walk down an aisle and do a movement disorder. Why not bring a telemedicine cart to the clinic that we built in Delaware and allow practitioners in New York State and these other locations to support those patients? I mean, common sense stuff that isn't going on right now, and these are the types of solutions that can be offered. This is like a telephonic cart. It's a way to do a telehealth like in a retail environment, and certainly under the right kind of conditions in a closed room could be a HIPAA-compliant option for you to consider. How many are you familiar with the American Well and HealthSpot kiosks? Okay, they've made a really nice marketing and opportunities, and we're very excited about this model. We actually had the privilege also to work with HealthSpot early on to help build a marketing plan for the employer groups, because we see this as an opportunity because of some of the convenience of having all of the medical instruments built into it in a HIPAA-compliant, sterile environment. And it only takes up a space of about a 12 by 7 on the inside, and then it could be staffed by a med tech, nurse practitioner, but most likely it could be a wellness coordinator or someone that works on site who has the credentials to guide that patient. This individual is not in this room. It's meant to be a self-guided experience and controlled by the practitioner on the other side of the screen, and we'll talk about that in a second. But my point is, if you're looking for an efficient way to implement this, the things that HealthSpot are doing are working with provider groups to have this to be one of your individuals who would be there maybe throughout the year doing flu shots and cholesterol screenings and wellness programs, but also have a self-directed opportunity linking practitioners to the hospital. So this physician is able to control that dermoscope, and I think what's important is that all of the instruments are of the same quality as you would have in your clinic. So it's Littman stethoscope, it's Welch Allen equipment, and they're controlled by the practitioner on the other end of the video. So the otoscope is put into the individual's ear and guided by the clinician and controlled. The door only opens for that particular instrument. What's important here is, look at this. This is that suspicious mole that individual didn't realize they had, and this is the inflamed eardrum of that person. Remember we talked about technology empowering individual? First time I looked inside my ear, I was like, oh my God, I had no idea that an ear could be so ugly. But if it was inflamed, I would be very apt to take my amoxicillin and erythromycin and be empowered to know that this is my condition. And how empowering is that? And that's why the results that are coming out of the early deployment of these HealthSpot clinics and other telemedicine are showing it, people like it better. You don't have to wait for the clinician, and your own room. It can be conversational. Cleveland Clinic owns a dozen of these. Kaiser has them. They're being placed in Florida by large institutions. So they are becoming more scalable. And it's a great option, and there's many other vendors that have this as well, as I mentioned to you, American Well, but it's a great concept. And it's controlled very simply with a high-definition camera, and this clinician is controlling the doors on that unit, and all you need is a laptop, which keeps the cost down as well. And so everything's self-contained. They have their own EHR system that's cloud-based. The clinicians on the other end are actually teledoc clinicians if there's no network. So all of these providers offer both options, both a teledoc option, a network option, and a non-network option as well. And again, some of the early results, this is a primary care organization, IPA, that had used the early experience with HealthSpot, and it has been very favorable. telepresence is actually a trademark name that Cisco came up with over a decade ago, but it's being used more and more by organizations that are bringing in high-end video resolution along with those same medical instruments. But unlike the kiosk, this is now guided by a nurse, and it's in a what is called a care space. So it could be a 12 by 10 room inside an employer or one of your clinic rooms, and it is guided by a practitioner and a professional. Same thing, real-time heartbeat being heard by the clinician, but the difference is this is Jetson stuff. This is like you and I talking here. The quality of the image, there's no delay in the voice. The imagery of the cameras is all proprietary to a couple video companies who have cornered the market on this telepresence technology. And unlike the other unit, the HealthSpot that was controlled by a laptop, there is a special type of device that has that mirror imaging. So there is a different, if you will, monitoring station that clinician uses in a telepresence experience. And these early results from the telepresence programs that have been implemented mainly in Ohio, because Ohio seems to be a very friendly state for telemedicine laws, have been very successful, and a number of rural hospitals have embraced this. And these are the groups that are getting the 100% reimbursement from all the major carriers, except for one. So a number of the clinic advantages, and this goes for both a HealthSpot unit as telepresence, are some of the things that we're talking about, but I'd like to share with you the small employer location as being a tremendous opportunity for a number of organizations in the room. The fact is that you could do a hub and spoke and also expand your clinic models to smaller because of the more efficient staffing and the lower cost of build out. And I'd like to kind of wrap up in the next minute or two just to share with you the advances in home monitoring and a couple of the tools that you're going to want to consider if you're ever opening up the clinic. The same types of devices that are being used within the HealthSpot units and others also can be used and instructed at home. Many of you are familiar with it. And it creates an opportunity for telehome monitoring, which is the biggest growth area, to be part of that network of your telemedicine clinic and being controlled by the clinicians on the other end. The final slides I just want to share with you are things that you all are probably implementing in your clinic right now but need to be part of a telemedicine clinic solution if you're looking at it. Having a claims analytics tool, making sense of the workman's comp and disability claims along with your lifestyle management and coaching. We go into a lot of organizations, our own employers, and it's scary that employers have all of the data in silos and don't have a number of different what I call dashboard products available to make sense of it all, to make business decisions. So we really encourage you to take a look at those different vendors that have those types of data analytics. Predictive modeling, you all are familiar with on the claim side. There's predictive risk modeling as well. There's organizations that have the next generation health risk assessments that do that kind of predictive risk modeling and predict costs. And also on the nutrition side, a personalized food frequency questionnaire that's USDA, NIH developed that is now being implemented in employers. It's used in translational research studies at Mayo Clinic and others. So there's evidence-based tools and processes that you would want to have in your operation, no matter if it was telemedicine or not. But we're a big proponent of these, and we get asked a lot of questions, so I wanted to be sure that you all had a lot of this information. We're also a big proponent of wellness portals that gather all the information, and we'll have a discussion afterwards after Donna shows you how to put all this together.
Thank you very much, Stuart. Just join us in the panel section. I would appreciate that. So again, let me introduce Donna Lentini. Donna is currently employed at Pitney Bowes as nurse practitioner and clinical site supervisor for their Danbury location, which hosts about 600 employees. The clinic is responsible for prevention, health screening, sick calls, and general counsel. in bringing the clinic services outside the confines of the clinic. She's been instrumental in the startup of their ongoing telehealth program. So please welcome Donna Latini.
Thank you all very much for having me here today. Can you all hear me now? Okay, great. Donna Latini from Pitney Bowes. Very happy to be here. And I'll just talk a little bit about what Pitney Bowes does and how we've developed our American Well telehealth platform. Okay.
Okay. Press run. Let's go this one. Right.
So a little bit about Pitney Bowes. We've been in business now for 91 years, and we're really striving and changing the company on a daily basis. Everybody thinks of Pitney Bowes as the postage meter machine, and it is our legacy business and a very big part of what we do. But we've also done a lot in terms of information technology, a lot of location intelligence, a lot with e-commerce, shipping, delivering. We've recently acquired an additional company within the last month called Border Free to add to our e-commerce. And that essentially helps us to assist Amazon and companies like that to ship across borders, across the world. This is a little bit of a breakdown of who our employees are. The first is small and medium business solutions. This talks about our meters, our printers, our inserters, and sorters. Those type of machineries are things that you'll find that American Express might do a big mailing or welcome to the neighborhood. We're able to target people. We know where you live. We know what your hobbies are, how many children you might have, what your level of education is. And so we've been able to take that technology and put it into a platform where we can then deliver for people like American Express and Chase, et cetera. So we have 4,000 people in that role. We have between 700 and probably now more recently closer to 1,000 people in communications. And that was the e-commerce that I talked about. Then we have our pre-cert sites, and that's 4,000 employees. Across the nation, we have these small sites that will sort the bulk mail. These are our lower-paid employees. These are probably our sickest employees. We do not have clinic sites there. And so part of the telehealth platform is we're trying to reach these individuals that may not otherwise get the care that they need. So I'm going to give you a little bit of a background about the clinics. We currently have 5 clinics across the United States. 3 of them are located in Connecticut. I'm out of the Danbury location, and we have about 550 employees there. We have Shelton, which is not too far away, with another 800 employees. And then World's headquarters, which is in Stamford. That's been a big change for us. We've recently gotten out of our big building and really downsized, and there's only 250 employees, but there was a commitment there from the executive suite that they wanted the clinic, and it is very well utilized and appreciated. We also have Appleton, Wisconsin, and Spokane, Washington. Those are generally call centers. Also a population very much at need, a lot to do with dietary concerns, weight management, sedentary lifestyle, and work. We are accredited by the AAAHC, and that's 3 times in the running. So what do? Disease management, people who have high blood pressure, diabetes, obesity, things like that. We do a lot of education, try and assist people to reach their goals and to live a happy and healthy life. Wellness screenings, that's our biometric screenings. We also do mammographies. We do skin cancer screenings, osteoporosis screenings, and sometimes we'll have special events for prostate screenings, et cetera. Immunizations, that's just regular health prevention, but we also have a robust travel medicine, and that will include a lot of the immunizations. We are now, over the last 2 years, offering the virtual and telephonic consultations or the telehealth. And again, I'm sure pretty much what goes on in most of your clinics, episodic care, emergencies. We have a chiropractor on staff, We have a nutritionist on staff. We have EAP. We have a massage therapist, travel medicine, and very regularly we do ergonomic assessments. So what are our healthcare objectives? Basically, we want a healthy population. We've been committed to health and wellness for over 20 years now. It is a corporate goal. We put a tremendous amount of energy and staffing into this. We encourage people to use their health services, help them to make informed decisions not only for their health, but for their financial wellness. We want people to take ownership. We do a lot by way of educating people because we feel the more education there is, the more propensity there is for involvement. And in doing this, we're avoiding unnecessary absences, and we're offering affordable insurance for Pitney Bowes. So telehealth helps us to achieve these goals. And how does it do that? On every level, it will supplement the primary care delivery. So you have your primary prevention, we have our clinics, and now we're able to offer a telehealth platform. It allows for lower copays for effective delivery. It's very reasonably cost. It's somewhere between $10 and $39. It extends the clinic services. So many times we'll have follow-up visits via telehealth. People are working from all different locations across the United States. They're on trains, planes, and cars, and so we may see them on a Monday and then see them again that Friday by the end of the week through telehealth. And we get a lot of resources from our suppliers. We went with American Well. First, we did have a pilot program with them, so that's something that we worked through. They were able to offer us some branding. We do have a storefront that they customized for us, so that was terrific. It's real-time eligibility. They're always accessible. We have 24/7, 365 days a week. You can get a doctor on call. During the working week, Monday through Friday, you can get a nurse practitioner who's a Pitney Bowes employee, and that is free of charge. Other providers like dietitians are done by appointment only. So we get, now the rating is actually 4.8, the most recent information that I have from American Well. So there's a high level of satisfaction. People are enjoying it, they're finding it convenient, and it's helping them to stay healthy. So we have our physicians through the PPO fund or the health fund or the HRA fund, and there's a $10 copay with that. If you have an HSA, it's a $39 copay. If you do not have Pitney Bowes insurance, it's $45. Who's eligible for it? You can have family members, you can have your children, they're all eligible. As I said before, the nurse practitioners are available all week, and that's free for employees. Dietitian is available. We also have something unique, Johns Hopkins Nurse Navigator. And basically what she's helping us to do is to manage cancer at work. So if you have cancer, if your wife has cancer, if you want consultation, if you want to know how to work out a schedule, a manager can also use this and say, I have an employee with cancer. How can I be sensitive to their issues? What is my expectation? What is my role in that? So it's been a wonderful program, and the employees really enjoy it. We also have EAP, but that is by appointment. That is not an on-call type of a thing. So who are our providers? We have our nurse practitioners. They're managing ongoing conditions, as I said before. We also do tobacco cessation, and you can do that via telehealth. And that's a wonderful thing because we have the 5 clinics, but we have people that work nationally that don't have a clinic nearby. So this allows them to go through things like tobacco cessation. Registered dietitians, again, what our registered dietitian will often do is she'll go to the different sites to build relationships at the pre-sort sites or at locations where we might have 100 or more people, or that we realize that we have an obesity issue, and then she will follow up by telehealth or by phone call, depending on the employee's preference. So that helps to build relationships, but also helps to get help to people who need it. We do also have Express Scripts that is available, so a pharmacist on call if you'd like a pharmaceutical consult. This is our storefront. So when you log on to Amwell, we have a special key that's for Pitney Bowes employees, and you can see the providers will all have a Pitney Bowes banner on them. And so then you know that you're contacting somebody who works for the organization and that there is not a fee involved. If you choose the doctor because that's what you need, then you will be billed for it. So they are able to see that right off. So some of the challenges that we've had is the marketing of it. Change doesn't always come very easily, especially we have a middle-aged population, and we've really gone all out, and Amwell has been tremendous in assisting us, giving us the tools that we need to advertise. So we have a lot of flyers. There was a home mailer. When we initially rolled out the plan, it did not coincide with enrollment. So we were offset by about 6 months, and that was a little bit of a struggle. But once the enrollment period opened up, we were sure to have those materials available to people. So we did a direct mail in the clinics. It's very much promoted. We have a lot of materials. We also have a little card here that you can see at the bottom that we give to people so they can download the app to their telephone and make it very easy for them to use. At all our sites, we have a wellness champion, and we provided them with education via webinar. It's on digital screenage, so we have digital screens at all our sites to promote this activity as well as other activities. We do on-site biometric screenings across the country through a contracted firm, and we also promote during those times. So these are some of the results. 73% of employees diverted costs from a more expensive setting. So when you don't feel good and it's a weekend and you can't get hold of your doctor, most people are going to go to the urgent care. And you know that can cost as much as $75. If they don't have an urgent care, they might go to an emergency department, which would cost well over $100. So we have been able to appreciate savings both from the corporate side, but also the employees are saving money by using telehealth. Satisfaction rates are at 4.8, and we've had 119 unique visits. 23% have been repeats. So we're finding that people are much more likely to reuse it than they are to take the initial plunge. So we have 1,056 employees enrolled. We have about 9,000 people across the country. So we did make a big push for this. It was a grassroots effort. We went out and literally to the population. We went to the different sites. We held breakfast, a big campaign, and we enrolled many of these people because we felt that would break down one of the barriers. Once they were enrolled, they might be a lot more likely then to log on and get them through those initial steps. 174 visits to date, and you can see the breakdown there in terms of what kind of provider they saw. 41% of the employees saw a Pitney Bowes provider. So again, there is a big push through the staff to try and get people to utilize the system. The online care doctors, 59%. These are some of the prescriptions, diagnoses, and the specialties that are used. Also, what I don't have here is the time of day. We were thinking that most people would reach for telehealth at midnight. It turns out it's between 9 and 12. So I think they're at their desks, they're not feeling so great, and they're thinking maybe I can get a handle on this by logging on and getting myself the care that I need. Or maybe they called their doctor and they said, I'll see you next week, and that wasn't going to work, so they went to American Well. So the top prescriptions, again, I don't think there's any surprise here. These are many of the prescriptions that you've seen or that are very commonly prescribed, amoxicillin, Augmentin, and Azithromax. So we're seeing mostly sinusitis, upper respiratory infections, counseling, injury prevention. That speaks to our travel visits. That's the way we code our travel visits. So we have people flying internationally, and we offer a travel program, and we do that through American Well as well, and acute pharyngitis. Some of the other more common ones would be pink eye, UTIs, things like that. Family physicians, 101, nurse practitioners, 62, RNs, and others. So that's the breakdown. What have been some of our barriers or challenges? So it was a big effort to get us all trained. We worked closely. There were many sessions. We're a technology company, but I can tell you we had a lot of issues with technology, a lot of problems with the camera, connectivity issues, and there are still some locations in the United States that we have difficult times with the broadband. So we had to train the staff, and then we had to get the employees to take that extra step. And some people are very savvy, and some people are not. And so those are some of our challenges. For me, this is a little bit of an issue that there's no interface between my electronic health record and the electronic health record of Amwell. So that really means twice the work. I write the notes twice. So hopefully that's something that's going to change. They promised, but we're waiting to hear. Also, like anything else, change doesn't come so quickly many times. This is just some testimonials from our employees. The top one, she was post-surgery, and you can imagine how that happens. You come home from surgery, and they give you a little card, and you really don't know what to expect, and it wasn't on the paper, and who can I call? So Sandra was able to do that post-surgery. Diane woke up, she had a big trip, and she didn't feel well, and she was able to contact the doctor and get a prescription and was able to go do her trip. And that's it. So thank you so much.
Great, thank you. So let's take some questions for Stuart and Bethany. We'll get a microphone to you in a moment.
Hi, Sandy Margettis with AbbVie again. I was really interested in your, Donna, your wellness champions, and I was wondering if you could speak to that role a little bit more. Is this a secondary, volunteer position, and is there an educational requirement?
It is a volunteer position, and I have to say I really appreciate the work that they do because it's very involved. It's very time-consuming. They put a tremendous amount of energy. It is coordinated by our wellness team. So there are webinars, there are conference calls on a regular basis, and what those champs do is they bring the programs to these off-sites. And again, I like to focus on the pre-store because I think that those are our neediest population. And so we have something called 1 in a Million Walk. And so everybody gets out there and walks. Everybody gets a pedometer. Then they register their steps. And we wouldn't be able to run those programs without the wellness champs. So they are very much involved. We do provide education for them, and it's volunteer, and it's a lot of work. So we really appreciate it. We do raffle off Fitbits and things like that to show our appreciation. But compared to the work they do. You're welcome.
Question? Jamie? Yep.
Jamie Stalker again with Argonne. So I always feel like I'm a bit of a naysayer about things, but there are just a couple of things. I know I'm a little bit older as a practitioner, but I embrace technology, and I think telemedicine is a very interesting future for all of us, but I think it has to be approached carefully. So my questions, I've got first one question about metrics. The metrics we saw at the end of your presentation were utilization, avoidance of cost for more expensive things. We saw usage of medication. So let's start with the medication. So as an internal medicine doctor myself, we struggle all the time with overutilization of antibiotics.
Right.
So what I'm kind of concerned about with all of this is, you've got a telemedicine interface going on. Someone doesn't feel well, they're going to hit the road. They're seeing me in the clinic, and I'm not finding signs of a bacterial infection. they're not getting antibiotics. So overuse of antibiotics, which is something the entire world is struggling with because of resistance factors, is one concern. Second thing with the metrics is you kept on saying people being healthier. So I think maybe well-being-wise, they're healthier because they've been able to have that quick access. But I think it's a little bit risky. I think it's a little too soon unless you have the metrics to really say that you're assessing that people are healthier overall from an actual, not just mental well-being, I was able to access a doctor, but are they really healthier? And I say this for a reason, and it's based on experience. So you don't have hands-on a patient. And I admitted that new kiosks and things are a lot more closer to that, but in this kind of limited, rapidly evolving telemedicine market that's here now, where it's just a video interface, the cameras aren't so great, you're going to miss things, and you're going to misdiagnose. And we always know there's always a lag behind kind of the stats that come out from that. And also, the legal community hasn't caught up with it yet. So that brings up my second component is, how are you covering malpractice of these people who are, is Amwell covering the malpractice insurance for the people that are making diagnosis and prescribing, and particularly if you don't have connection of your EHRs. And so Amwell has one thing, you miss that this is the third call for the person that had the headache, and you're prescribing either the same thing or different things. The person just wants to feel well, but you're missing the brain tumor, that sort of thing. So that sounds very extreme, but 20-plus years of medicine, I'll tell you, it happens all the time.
Right. Well, in terms of the malpractice, the providers all have their own malpractice. So we don't have anything to do with what Amwell, how they protect their doctors. So that wouldn't be something that we would be dealing with. In terms of our patients, if somebody had called in, we're really only dealing with the local community because we have licenses to practice in the state of New York or the state of Connecticut. So we wouldn't be necessarily dealing with anybody outside of those states. And those are people we generally see. So the nurse practitioners are seeing people that we would be seeing in the clinic, and we do have their EMR through the clinics. And also you have to take a good history, a good health history. How long have you had the headache? Have you been treated for this before, et cetera? So whether they had come into the clinic or we did it via telehealth, the history is still, one of the most important components of the visit.
Moves very quickly, and there's frequently a lack of standards. So, yeah, there's a standard within medicine. You get a good health history. But as you start vending all this stuff out, who's doing the quality assurance to ensure that that sort of quality care is being provided? And knowing who your practitioners are as well that are interfacing. I'm not saying anything specifically. I'm just, as a group as a whole, I think it's things that we need to think about.
And that's why some of the states are reeling back because of some of the concerns you said. The state of Texas reeled back and said that the quality of the visit has to be the same as a regular office visit. The state of Florida laws in October are written the same way. So I think what you're seeing is an investment in some of the technology that we were talking about that actually would do a better job with avoiding some of those legal concerns that you brought up.
Thank you. Other questions? Donna, go ahead, Laura. Hold on a second. Get it. There you go.
David Stewart, the webinar has a question. Is it possible to restrict the telemed to just specialty care or to restrict the calls to only after hours since we have an on-site clinic for primary care?
I'm not sure if I understand it correctly, but what
You suggest for specialty.
Yes. So with the telemedicine laws that are governed by the state, each state is different, but for the majority, it's the same physicians and nurse practitioners and PAs that are within their scope of practice are generally approved. Also, Medicare has dietitians and some of the other ancillary professionals also can receive reimbursement as well.
And there's one more question from MJ Burkaw. For telemed visits, are employees seeing a Pitney Bowes provider or only American Well providers?
The employee has a choice of seeing a Pitney Bowes provider or seeing a doctor through Amwell. There are no Pitney Bowes doctors. There are nurse practitioners, dietitians, EAP, et cetera. So depending on what the employee is looking for and the availability, if it's an off hour, they wouldn't have the choice of seeing a Pitney Bowes employee or provider.
Other questions? Let me have a quick one, Donna. Some employers are concerned, and there's call lines, doctor lines in the past. There's been maybe 10, 15% of people engaged in it. There's a per member or per month charge. It seems very expensive. How are you approaching it? Are you getting high utilization, or is it a per call charge, or is it a per member? And then, what's the general cost and the ROI on that for you?
Larry, I'm sorry, I'm not qualified to answer that. I don't really deal with money. It's just about seeing patients. So that would be something for our benefits department to speak to. Okay, great. Stuart, what's your experience in that?
Yeah, there's a recent article that just came out a couple weeks ago, concern about the lack of utilization in the fee structure, the PEPM model. And again, I think that's going to be some of the shakeout, if you will, of telehealth, telemedicine, that you're going to see more competition, which will drive the cost down. But some of the early entries in the marketplace have been able to capitalize on the fact that there's been low utilization and be able to charge employers a PEPM fee as part of that benefit. And some of that's been driven by the brokers, insurance companies also, that have been making a market in it. So it's the reality of healthcare, but I think it'll shake out. My personal opinion is it's going to shake out very shortly.
Okay, great. Let's thank Donna and Stuart.